Emma Camarena is Clinical Nurse Specialist for Critical Care Services at Kaweah Delta Hospital. Dr. Frank Sabat is a practicing intensivist and Medical Director of the Cardiovascular Intensive Care Unit at Kaweah Delta Hospital. Dr. Sabat is a Fellow in the College of Critical Care Medicine, former co-chairperson of the Rapid Response Team Task Force for the Society of Critical Care Medicine, and a strong proponent for back to basics in the delivery of bedside patient care.
Do we recognize critical illness early? Probably not.
Research supports that the healthcare team does not consistently recognize critical illness in the early stages. There are early warning signs, such as tachycardia or tachypnea, that we either miss or do not recognize before a patient becomes seriously ill or before a code blue is called. Airway breathing and circulation is not always managed as well as we'd like before the patient is transferred to the intensive care unit. What are some of the national efforts to improve earlier recognition of at-risk patients? The Institute of Healthcare Improvement, or the IHI, has promoted rapid response in 1,500 U.S. hospitals. The Joint Commission has mandated some form of RRT in all hospitals, and the Society of Critical Care Medicine has developed a rapid response implementation manual, and the American Heart Association keeps track of those RRT alerts via a National Registry CPR database.
Now, in spite of all these efforts, not all rapid response systems, and many rapid response systems, in fact, do not demonstrate improved outcomes. So why is that? Well, I'm going to give you two scenarios that took place in rapid response systems that illustrate some of the problems. The first scenario was in a Northern California hospital, where they had recently implemented a rapid response system to recognize patients in shock earlier. And they had launched it not only within the hospital, but within the EMS system. So this was a 32-year-old female who had called 911 because she was lightheaded and she had pain in her feet. On arrival by the EMTs, they noted that she had a past medical history of a mitral valve replacement and was on Coumadin, but otherwise she had been in good health. The EMT noted that she had cool extremities, poor capillary refill, she was anxious, she was tachypnic, and she was mildly hypotensive by palpation. Because the patient met criteria being at risk, they called the base station, which ordered 1,000 cc's of fluid to be given, and launched the rapid response team within the hospital to come down to the emergency room on her arrival. On arrival, the emergency room physician and the intensivist, who was part of the team, responded to the patient's bedside. Now, the patient looked somewhat better. She was sitting up, but she was so anxious. She had a respiratory rate of 22 still, and her capillary refill was 4 seconds. Now, these are highlighted in yellow for you because by criteria that we're going to explain more about, this patient's still at risk. However, both the emergency room physician and the intensivist, based on their own intuition and looking at the patient, decided that this patient was not at risk, even though they met criteria. And so they called it off. Now, the lab had come in and drawn the rapid response team panel. But the primary care physician was notified and admitted the patient to the floor with a diagnosis of mild hypovolemia. By 2 o'clock in the morning, things were very bad. The patient was in extremis, and the nurses called it code blue because it looked like the patient was about to arrest. When the patient was transferred to the ICU, the responding intensivist went back and looked at the admitting lab, which had not been looked at because the alert had been called off. And in fact, they saw that the lactic acid was 7, the DIC screen was positive, and the platelet count was very low. So what happened with this system? Well, the person who really got it was the EMT. That person followed the protocol. The people who didn't get it were the two physicians who didn't follow the protocol, and as a result, the patient had a very bad outcome. We hope to avoid this as we go forward in our educational program today. The next scenario I'm going to present to you is a setting that took place in the Detroit emergency room in about 2000. And this was the work done by Dr. Manny Rivers which you may have heard of, early goal-directed therapy, where he was trying to recognize and treat sepsis earlier and more aggressively. Now, he had a lot of patients. He had about 300 patients. And the question he posed to himself was, if you're hypotensive, is your outcome better or worse than if you're normal-tensive? And so he looked at patients who were normal-tensive and had lactic acids of 4, so they were still quite sick. They had elevated lactic acids, they were very septic, but they had normal blood pressures. And when he looked at the data, the result was somewhat surprising. If you were hypotensive and in the control group, which did not get goal-directed therapy, but got standard therapy, the mortality was 46%. If you were normal-tensive, your mortality was 70%. Now, why would that be? Why would you do far better if you're hypotensive? Well, if you come in and you're normal-tensive, just like the ER doc and just like the intensivist, it doesn't trigger an alarm in your head. And you say, well, maybe this patient really isn't that sick. Whereas when a patient has a blood pressure of 70, you don't have to look at the patient anymore to say whether they're sick or not. You assume they're sick until you prove that they either are or are not. These are two examples of why you can implement a rapid response system, but if you don't adhere to best practice, you may not have an impact.
So what is the value of a system? Systems in trauma, acute MI, stroke, and shock have led to earlier recognition of patients in trouble, increased identification of these patient populations through nursing and physician education, and quicker calls for the rapid response team to provide additional resources to the nurse and to begin best practice interventions. All of these steps provide improved patient outcomes. Dr. Sabat will be talking about the rapid response system in just a few minutes, but what I'd like to talk about is a rapid response team. What is a rapid response team in a rapid response system? The rapid response team is the efferent arm of this system. They are the people who are most recognized and sometimes viewed as the most important part of the system, but they may not be as important as you might think.
Now, there's been a lot of focus on the team aspect, but as Emma has already indicated, the team may be a whole lot less important than you are. That is, the bedside nurse, who really represents the afferent arm, or the event detection. So you can't do much about a problem until you detect it. And even after you detect it, not much is going to happen about the problem unless you mobilize resources to help you. So 90% of the effort of the STARS program is really focused on the bedside nurse through empowerment of their practice through education. And the bedside nurse then has the ability to recognize critical illness sooner, mobilize the appropriate resources, that being the team, to get those additional resources to help you and the patient. Now, the other components of the rapid response system are very important. For example, if the administration is not capable of giving you the resources you need in terms of the team or the equipment and so forth, paging system and other items, then your effectiveness will be less. So you really need an administrative arm to make sure that both the bedside nurse and the team have the appropriate resources needed. The quality assurance arm is key to see if those resources are being allocated in a way that they really make a difference. And if they're not making a difference, why not? And how do you reallocate the resources so they do make a difference? Feed that information to the administrative arm so the administrative arm can then make changes to whatever the bedside nurse is doing or make changes to what the team is doing. So STARS, or Shock Team and Rapid Response System, is a complete system. That system focuses on the afferent arm for earlier identification, rapid mobilization of the rapid response team, making sure that the rapid response team is mobilized frequently enough, often referred to as dose of therapy, and to make sure that when the team gets there that they're administering best practice therapy that's likely to have an impact. Now, dose of therapy, we tend to think of that with antibiotics, we tend to think of that with vasoactive drugs, but we're not used to thinking of dose of therapy with a system. But it applies just the same. So if your system is not mobilizing your rapid response team very often, it doesn't make any difference how much resource you put into it, it's not going to make a difference. Now, this is data from a trial that had over 23 public hospitals in Australia. And in Australia, they refer to the rapid response team as the MET team, medical emergency team. But it's the same thing. And they looked at over 700,000 patients who had over 3,700 rapid response team or MET calls. And when they looked at that and they saw the number of calls as it related to outcomes, they saw that for every 10% increase a facility had in MET calls, there was a reduction of 2 cardiac arrests per 10,000 patients. Also, it was noted that for every 10% increase in MET calls, there was a reduction in unexpected hospital deaths by 1 in 10,000 hospital admissions. Now, you'd say that's nice, but 1 out of 10,000 patients is not a huge number. If you happen to be that one patient, it's pretty important, but it's still not a huge number. But there's more recent data to show that dose of therapy is very effective and has more improvement than those numbers suggest. For example, this is a review of the literature of 5 recent studies and was published in 2009. And when they looked at those studies, they saw a significant reduction in adverse events, code blues, and hospital mortality when the dose of therapy or the number of RRTs that were called per 1,000 exceeded 26. And some hospitals had as many as 56 alerts per 1,000 admissions. Now, what's the national range? Well, we know when you look across the board, and the American Heart Association keeps track of this data, hospital cardiac arrest per 1,000 is about 5 on the high end. And some hospitals have gotten all the way down to 0.25 arrests per 1,000 admissions. And the range of RRT alerts is very broad. As you can see, it ranges anywhere from 5 to 56 alerts. Well, the hospitals that are closer to 56 are also the hospitals that are closer to 0.25 arrests per 1,000. And the hospitals who are only mobilized in the rapid response team at 5 per 1,000 are the hospitals that have the highest code blue rate. Now, the STARS program is a collaborative effort between 2 hospitals. And if we look at the data of Cahuilla Delta, we have 3.38 or almost 3.4 arrests per 1,000. And we're mobilizing our rapid response system about 17 per 1,000 admissions, below the recommended level. Riverside County Regional Medical Center has about 2.36 codes per 1,000, and they are increasing their alerts slightly more than us by 22 per 1,000. Yet there's a huge opportunity for both facilities to reduce the code blue rate as well as increase the dose of therapy, and the two are very closely related.
Now what we need to talk about is which of our patients are at risk for failure to rescue. In 2003, Clark and Aiken defined failure to rescue as a clinician's inability to save a hospitalized patient's life when he or she experienced a complication, something that was not present on admission. Patients who are at risk for acute decompensation are patients who have suffered from neurological, respiratory, or hemodynamic deterioration. If any of these problems are left untreated, all will lead to shock. The criteria that we will be using will help us to more easily identify the patients who are at risk for failure to rescue. We are going to be using activation criteria such as the 10 signs of vitality that is sensitive and specific to this patient population. We need to keep the criteria simple so that everyone understands it and can use it without hesitation, and we will be able to assess and modify this criteria as needed.
The STARS program is utilizing the shock model to improve the standardization, recognition, and treatment of at-risk patients. And we will elaborate on this model as we go through the presentation.
A syndrome of global inadequate tissue perfusion is considered shock. As you monitor and assess your patient, some signs of shock you may see are altered level of consciousness, tachypnea, cool or mottled extremities with a capillary refill greater than 3 seconds, hypotension, which is sometimes present but not always, oliguria, metabolic acidosis, manifested by an increase in lactic acid and hypothermia. Hypoperfusion and shock lead to decreased blood flow to the brain, coronary arteries, intercostal, and diaphragmatic muscles. The effects of decreased blood flow to these vital organs can lead to altered mental status with an inability to protect the airway, inadequate cardiac function, and respiratory distress or failure. If any of these conditions are left untreated, the consequences can lead to code blue.
So we were using the shock model as a paradigm to get us to think about at-risk patients. So it's important for us to describe the various forms of shock, most of which are classic and I'm sure you've heard about. But we're going to introduce at the end a model of shock that is less conventional but very important. First of all, hypovolemic shock, commonly seen with GI bleeding, a dehydrated patient, or other causes of volume loss. Septic or distributive shock due to overwhelming infection, cardiogenic shock due to myocardial infarction or acute onset of other myocardial problems. Obstructive shock, we don't see very often but can be quite critical. Massive pulmonary embolus obstructing the flow of blood out of the heart, or pericardial tamponade, squeezing the heart and obstructing the flow of blood out of the heart. Anaphylactic shock, not common but very devastating, often due to an allergic reaction to medication in the hospital. And the less conventional form of shock that we're going to talk about is hypoxic shock. And the reason we're introducing this model is that if we only looked at the conventional forms of shock, there's a whole group of patients in the hospital we would miss. Those patients who are receiving too much narcotics, who can't breathe, who get hypoxic, aspirate, and get into trouble, or those patients who develop primary respiratory problems, such as congestive heart failure, pulmonary embolus, and so forth, who can't breathe. This is a large group of patients that we need to capture, and therefore we're adding hypoxic shock to the conventional form of shock. Now, this cycle of shock needs to be interrupted, but all of the forms that I just described to you can start this cycle in motion. So hypoxia, hypovolemia, sepsis, cardiogenic obstruction, and anaphylaxis all lead to the common denominator of decreased oxygen delivery to the tissues. Once the tissues recognize that they're not getting enough oxygen and become ischemic, the patient gets into trouble. This is where you want your rapid response team to intervene, early in this process where you can reverse it. However, until your system is mature and well-oiled and running smoothly, we frequently don't intervene at this stage. Further downstream, as the respiratory muscles, the heart, and the brain are more ischemic, you're starting to progress towards multi-organ dysfunction. You may be able to rescue the patient at that point, but it will result in a longer ICU length of stay. And some of them will progress to multi-organ failure and die. Later on, by the time these organs have gotten to the point where irreversible damage has been done, it's too late, and mortality approaches 100%. Now, this is a process improvement project at both Aquia Delta and Riverside, but it's also a study. And as you do any process improvement activity, you want to measure, is what you're doing making a difference? So we're going to be measuring, to the best of our ability, what's the impact of having a four-arm system as opposed to just the rapid response team? What's the impact of all of this effort we're going to put forth on the afferent arm? That is, what difference are you guys going to make armed with this material? Does the 10 signs of vitality, is it a credible recognition criteria set? Very different than the conventional forms of recognizing at-risk patients with an expanded variables that we're adding. What effect does the 10 signs of vitality have on outcomes? And lastly, can we automate some of the vital sign acquisition so that the LVN gets the information and it goes directly to the electronic medical record and alerts the RN that there's an abnormality in one of the 5 vital signs, and the RN gets the room number and the vital sign abnormality and goes directly into the patient's room and does a 10 signs of vitality assessment, with the ability to have the computer launch the rapid response team as the RN enters the 10 signs of vitality into or out of parameter. Will this automation further improve outcomes?
So as part of the STARS education program, we are going to be introducing a way to earlier recognize at-risk patients. Florence Nightingale used temperature, pulse, color, and respiratory rate as classic vital signs. She used color instead of blood pressure because when she was assessing patients, color is what she was available because the ability to measure blood pressure had not yet been invented. Pain as the fifth vital sign was added by the American Pain Society in 1995. Since pain has been added, there have been studies that have shown that in some hospitals there has been a 200% increase in respiratory failure. This suggests that we may be treating pain too aggressively. In addition to our classic vital signs, we are adding an expanded assessment which include the level of consciousness, O2 saturations, urine output, capillary refill, and in addition to that, we have our base deficit, lactic acid, or SCVO2, all which reflect global tissue perfusion. In addition, on number 10, sometimes you may see base excess instead of base deficit. If you see a base excess of -5 or a base deficit of 5, both terms are frequently used and communicate the same information, a deficiency of bicarbonate in the blood due to a metabolic acidosis. So altogether, all of these vital signs represent the 10 signs of vitality. You will be given a lanyard card that has inclusion criteria for calling an RRT alert. We will discuss this more in depth later in the presentation. What you are seeing on the screen is the front of the card that shows our early warning system or the 10 signs of vitality.
So to add to what Emma said, you will notice that there is a red line on this card. So along the green line are the 10 signs of vitality. An abnormality of any one of those 10 should prompt a further assessment. Once you have all 10 signs of vitality, you need to put them together. And if 2 fall below the red line, your patient's at risk until you prove otherwise. An example might be of a patient not at risk where you've got a bradycardia, heart rate of 40, or a tachycardia, heart rate of 120. Yet capillary refill, mentation, urine output, and the other parameters are all fine. It will necessitate a call to the doctor to inform him of the change. But the patient does not need an RRT call because they are well perfused, at least at that moment in time. Whereas if the converse were true, let's say you had a patient who had a heart rate of 40, but now they're not making urine or the capillary refill is 5 seconds or they're altered, that would necessitate a call not only to the physician, but launching the rapid response team.
So some of the at-risk triggers that you should be aware of but can be easily missed are anxiety, apathy, tachypnea, capillary refill greater than 3 seconds, hypotension, and oliguria.
Apathy can be an early sign of cerebral hypoperfusion. For example, if your patient is less concerned about their worsening condition than you are, and they have not received any narcotics or drugs that would account for their lack of concern, this should prompt further evaluation.
Tachypnea is usually always present but not specific to any one issue. Here at Kaweah Delta and for our 10 signs of vitality, we're going to be using respiratory rate greater than 20 as our trigger. Hypotension, which is not always present or detected, is another sign. You'll always need to double check your blood pressure by a second method. For example, in addition to the automated blood pressure, you might want to verify that reading using manual or Doppler pressures. Another trigger is oliguria, which takes time to assess, usually about 2 hours, but is important to recognize. So now that we've discussed the general manifestations of at-risk patients, now we're going to discuss body systems affected by shock. So as I stated before, the central nervous system manifestation of at-risk patients include anxiety and apathy as early signs leading to lethargy, stupor, and coma as later signs if shock is left untreated.
Now, the largest organ of your body is the skin, and it's very important. You can't live without it. However, during periods of hypoperfusion, the skin has adapted and can live quite well with very low flow states or almost no blood flow for a number of hours. As a result, if a patient develops hypoperfusion, mechanisms have developed by which the blood flow is diverted away from the skin to more vital organs. And what's left over is blood that's in the capillaries that becomes desaturated because there's no arterial inflow to the skin to push that blood out. So as whatever blood is there becomes desaturated, it turns blue and it pools in these venous lakes. In this skin modeling that you see on this slide, known as livedo reticularis, is a very important sign of hypoperfusion. If you see this, your patient's at risk until you prove otherwise. Of course, it may be that your patient just came out of the operating room and they're cold and both legs look like this. Or it may be that they have peripheral vascular disease in one leg or another, and you see this in one leg or another. But when you see this, you should not assume that it's due to peripheral vascular disease or due to exposure. You should assume that your patient's at risk. Go through the drill, go through the 10 signs of vitality, and then if 2 of the 7 aren't met, then you've proved to yourself your patient's not at risk and this is due to something else.
Abdominal manifestations of shock are oliguria, ileus, increased liver function test, and temperatures less than 96.8 degrees. So if your patient has decreased blood flow to the kidneys, what you might see is oliguria, or a urine output that's less than 30 mLs per hour for about 2 hours. An ileus might be present and is a sign of decreased blood flow to the bowel. Decreased blood flow to the liver are manifested by increased LFTs and hypothermia. Hypothermia is present because the liver is the main organ for thermogenesis.
So, not frequently appreciated is that all shock, septic shock, hypovolemic shock, anaphylactic shock, leads to cardiogenic shock. Now, why is that? Well, as illustrated into this picture, the coronary arteries are the first arteries off the aorta and are meant to see the first drop of blood being pumped out of the ventricle. Now, if you're hypotensive, there's not enough blood going through your coronaries. And Dr. Rivers, when he looked at the 300 septic patients that came to his emergency room, much to our surprise and everybody else's, they were in low cardiac output states. So although we think of sepsis as being a high cardiac output state, it is basically an element of cardiogenic shock along with hypovolemic and distributive shock until you volume resuscitate the patient. Once you push lots of volume, you will convert them from a hypovolemic, hypotensive patient to a better blood pressure and now a high output shock state in which the peripheral vascular resistance is the problem. To reinforce this concept, on the vertical axis is coronary blood flow. On the horizontal axis is mean arterial pressure. And as you can see, they are related linearly. As mean arterial pressure drops from 60 to 50 to 40, coronary blood flow goes down proportionally. It is important that if you have a hypoperfused patient and they're hypotensive, that you need to do everything you can to raise mean arterial pressure so that the coronaries are well perfused. So if you start off with sepsis, you don't end up with an element of cardiogenic shock, or if you start off with hypovolemia, you don't convert the patient to myocardial ischemia because of inadequate coronary perfusion.
So what we need to know about early recognition of at-risk patients is we need to know the early signs of critical illness. We need to have a high index of suspicion, and once you raise the question of critical illness, we need to perform the expanded assessment, which is the 10 signs of vitality. We also need to activate the rapid response team if all the criteria are met. We need to make sure that the burden of proof is on the caregiver. So the burden of proof is on you. Prove to yourself that the patient is not at risk. Now we're going to be talking about the golden hour. The golden hour is the first hour after the onset of illness, which if recognized and treated, results in the best outcomes in trauma, acute MIs, stroke, shock, and likely important in other at-risk patients.
To further this concept that Emma has talked about, the golden hour, we had a study that looked at some 500 patients that came to a hospital over 5 years in shock, either through the ED or 30% of the patients were actually on the hospital floors. And they looked at, before they implemented a rapid response system to recognize these patients earlier and intervene more rapidly, what was the time it took to get 2 liters of fluid or antibiotics? Well, it took over 4 hours to get 2 liters of fluid, and it took over 3 hours to get antibiotics from the time the patient should have been recognized that they were at risk to the time somebody actually brought those resources to the patient. Now you can see that year 1, which was the first year the rapid response system went live for these patients, interventions dropped. The second year, some interventions dropped, some went up a little bit. Third year, interventions dropped. Fourth and fifth year, interventions continued to drop. This tells us a number of important things. When you implement a system, you don't see benefits in 3 months or 6 months. And you may not see maximum benefits for years as the system becomes better organized and more fine-tuned via the quality assurance arm or the administrative arm implementing process change. Now, by year 5, most of the interventions were within what we're referring to as the golden hour, and there was a dramatic impact on outcomes. And mortality over that 5-year period dropped from 50% in the control arm for combined hypovolemic and septic shock down to 11% mortality for combined septic and hypovolemic shock by year 5. This was reinforced when you took all 500 patients over that 5-year period and said, okay, let's break them out. For those patients who got resources within the first 30 minutes versus 90 minutes and after, what was their outcome? And you can see that if you got recognized and a number of resources started within 30 minutes, your mortality is about 15%. If it took up to 90 minutes, your mortality was up to 25%. And by getting interventions later than 90 minutes, your mortality increased to 35%.
So let's talk about antibiotics. In 2006, Kumar studied the efficacy of early antibiotic administration. He studied more than 2,000 septic patients at 10 different hospitals. What he found was improved survival for septic patients with effective antibiotic administration. Patients who received antibiotics in the first half hour had a survival rate of 83%. And as you can see by the chart here, as time went on, survival rate decreased. So what Kumar has demonstrated is there is a 7.6% increase in mortality for each hour of delay in antibiotic administration.
Now, I'd like to add to what Emma said. I knew an intensivist who presented to a hospital with a ruptured appendix and was septic. And the first thing he did is he pulled out his cell phone to call the pharmacy and wanted to know where his antibiotics were. Now, if we can institutionalize this kind of response instead of having to have people use their cell phones, we're likely to make a difference. So we've talked about shock as a model to recognize patients earlier. Now we're going to take the shock model and use it as a way to bring best practice more rapidly to the patient. And Max Harry-Weil in 1969, who's really the father of critical care, developed an algorithm for treating forms of shock called the VIPPS approach. Dr. Randy Waxman and myself in 2005 added the AOV to this mnemonic. We now refer to it as the AOV-IPPS approach to the treatment of shock. Now it's like the ABCs of treatment. You want to make sure you got an airway, is the patient breathing, we got circulation. So we always use mnemonics in a way to make sure that we don't gloss over basic, fundamental, best practice care. And this mnemonic applies to all patients at risk. So AOV for addressing the respiratory system, I for infusing volume, P for does the patient need pressors to raise their mean arterial pressure, or is there something wrong with the heart or the pump that we need to be addressing? Pharmacy, do we need antibiotics? Do we need steroids? Is there something that the pharmacy can add to our armamentarium to turn this around? And then lastly, specific interventions. Does the patient need to go to the operating room for an acute abdomen? Do we need an endoscopist to stop GI bleeding? To elaborate on AOV, airways are sometimes overlooked. I've walked into a room and saw a patient with decreased level of consciousness and they're snoring. And it doesn't immediately always come to me that the reason that they have decreased level of consciousness is they really have sleep apnea. They're obstructing their airway and their CO2 is 90. And I had a gentleman who would go from periods of almost apnea and obstructing his airway to severe agitation. And so he was getting more Ativan for his agitated episodes. Once we put a nasal trumpet down, he didn't need any Ativan, he went to sleep. He didn't obstruct his airway anymore, his CO2 went to normal and he was fine. So sometimes we miss some basic things like, do we really have a good airway on this patient? None of us, I think, miss the fact if the patient's hypoxic that we're giving enough oxygen. But what we do miss frequently in a patient who's hypoperfused is addressing the work of breathing. Now think about this. You're oliguric, your blood pressure is 80, you're tachypnic, you're a little tachycardic, and you're breathing 30 times a minute. Now, where is most of your energy expenditure going to? Well, it's going to the heart to keep it going. It's going to the brain. And it's going to the diaphragms and intercostal muscles to keep you breathing. None of the blood's going to the abdomen. It's being diverted away because you're hypoperfused, and none of it's going to your skin. Now, how could you turn this around? If you put the patient on assisted ventilation of some sort or other, BiPAP or intubation, 50% of the cardiac output that was going to the intercostal muscles and diaphragms now are free to go to the abdomen or other vital organs. So simply supporting the respiratory system in a hypoperfused patient can make a dramatic improvement in outcomes. And there were studies done in Glasgow, Scotland, which showed a near 50% reduction in mortality of septic shock based on early intubation alone, even when the patient didn't look like they needed to be intubated, if they remained in shock and didn't come out of it quickly. Now, there are basically two types of hypoxic shock. We have the patients who won't breathe because of too much narcotics or sedatives. We have the patients who won't breathe because of CO2 retention or elevated blood ammonia level due to liver disease, or maybe strokes, particularly in the brainstem. These can be fixed, of course, by making sure they have an airway, assisting their ventilation, and giving them adequate oxygen. But the same is true for the patients who can't breathe, which is a very different group of patients. These patients tend to be tachypnic, where the group I just explained tend to have low respiratory rates. The tachypnic patient frequently has an airway problem, maybe a pulmonary shunt due to congestive heart failure or pulmonary embolus or acute lung injury, or a ventilatory defect such as asthma, COPD, pulmonary embolus, and so forth. Yet they are corrected with the same intervention: securing the airway, giving them enough oxygen, and assisting with ventilation. Now, once we get past AOV, we're now still have a hypoperfused patients. We need to look at fluids. What's the role? How much volume do they need to try to improve cardiac output and blood pressure to improve vital organ perfusion? Do we need a central line? Are we giving fluid fast enough? Do we consider colloid? And of course, if the patient's anemic and they're hypovolemic, you may consider transfusion. Looking at the P is very important. We've already talked about how important it is to raise the mean arterial pressure to perfuse the coronaries so that you don't get worsening myocardial dysfunction. This is frequently done with norepinephrine to raise the mean arterial pressure while you're trying to sort out other problems. If you have a dysrhythmia, a severe bradycardia or tachycardia, this may be interfering with cardiac performance, and you will be addressing that with the physician. And lastly, are there other problems with the pump that we need to address, such as valvular abnormalities, ischemia, and so forth? And lastly, we've talked about how pharmacy is a key part of the team. Need to assist us with getting drugs ready for intubation, or antibiotics for sepsis, dobutamine if you've got an adequate blood pressure but still low cardiac output, or if you're hypotensive, Levophed, and so forth. And lastly, what specific interventions might be needed to rescue this patient? Do we need to stop the bleeding with endoscopy? Do we need to take the patient to the operating room for an acute abdomen?
So you've been given a STARS activation or lanyard card. The front of the card gives you information about the 10 signs of vitality that were mentioned by Dr. Sabot and myself. At the bottom of the card is a section on SBAR communication, where for a situation, you'll be given the reason for the call and the acute problem, background, the reason for admission, current diagnosis. You have your assessment where you want to give let the physician or the rapid response nurse know about what you found during your 10 signs of vitality, and any type of recommendation that you might have. The back of the card are your interventions, which include the AO VIPS mnemonic for resuscitation. There is also a section for labs to be drawn, which are color-coded and correlate with the 10 signs of vitality on the front of the card.
And to elaborate a little bit on the color coding, if you notice, 2 of the vital signs below the red line are black: respiratory rate and SaO2. If those are the two abnormal parameters present, you have pure hypoxic shock, either due to the won't breathe or can't breathe. Those people don't need fluids, they really need AOV, and so they're in black. Whereas patients who are hypotensive, have decreased blood flow to the brain, extremities, kidneys, or a lactic acidosis, for example, are hypoperfused and not only need AOV, but need the IP that's color-coded in blue on the AOV VIPS resuscitation, as well as additional laboratory for those patients to recheck a lactic acid in 4 hours to see how you're doing with improving perfusion and so forth.
So when you call a rapid response, the responders will be the critical care nurse who may choose to call the intensivist for additional help, respiratory therapist who will be able to assist the patient with any respiratory issues, the pharmacist who will be able to provide guidance and suggestions for medications, and the phlebotomist who will be able to provide timely lab draws. The RRT is activated by the primary nurse, any member of the healthcare team, or family member. A physician order is not required. You need to call 444 at Kaweah Delta or 911 at Riverside, give the room number, and you will need to contact the primary care physician. The primary care nurse will remain at the bedside and assist the team providing vital information in SBAR format. The lead nurse will redistribute the primary care nurse's workload and assist the nurse in obtaining patient information and equipment. Now let's talk about what you can expect from the rapid response team. The RRT nurse will be asking questions about the patient's situation and background, listening for information that you have obtained using the 10 signs of vitality assessment. They may choose to reassess the patient. The team will begin AOVIPS interventions looking at airway, oxygenation, ventilation, infusion of fluids, assessing cardiac function, pharmaceutical interventions, or getting the patient ready for an intervention outside of the unit. The RRT nurse has protocols and standardized procedures that they can implement. So once all the information is obtained, you will be able to relay this information to the primary care physician using SBAR communication for orders. The RRT nurse may choose to call the intensivist to begin more rapid interventions such as intubation or placement of a central line for rapid fluid infusion of fluids and to monitor fluid resuscitation. The lead nurse or someone who has been designated will need to document the assessment and treatment on the rapid response record. So the rapid response nurse will facilitate a debriefing with you and any other staff involved or interested following the rapid response event. At this time, you're going to be talking about what went right, what went wrong, what else can we do to improve the process. We'd like for you to take home these key points to this STARS education. We want you to be empowered as frontline providers to recognize early your patients who are at risk for severe illness and to activate the RRT sooner.
We're going to increase the activation of the rapid response team by hopefully increasing the dose of therapy into the range that we know improves outcomes.
We want to see implementation of the AOVIPS resuscitation to make sure that best practice and early goal-directed therapy is brought to the patient quickly.
And hopefully you're going to see improved outcomes by intervening earlier and having the patient remain on the unit.
Rapid transfer to the ICU or surgery for improved outcomes.
Or simply making sure that the code status is clarified and potentially changed, in which case you're matching resources best with the patient's desires.
So just to reiterate, a physician order is not required. Activation of the rapid response team is an independent nursing function. So remember, you must have a high index of suspicion, go through the drill, activate early, rapidly mobilize the troops to improve your patient's outcomes.
So we wish to conclude our educational program today and hope that the information that you have been given will help empower you to improve outcomes at your facility. Thank you for attending.
Thank you.